Yeah, thanks for having me. There was a good chance I wouldn't have been able to make it because a week ago I was in the ER. I hurt my back really bad, and I couldn't even get out of bed. But I don't know, from I just got better a few days ago and just managed to fly in. So today I'm talking about characteristics and comorbidities influencing mortality risk amongst hereditary angioedema patients. I'll keep that as HA for short. So this is one chapter of my dissertation that I published, and Stefan read my paper and was kind enough to invite me to present. So as I go along, I'll break down all these words for you and what do I mean by mortality risk or comorbidities. But just quickly, bit of background for me. So I did my master's in applied statistics in 2019 from Villanova University in Pennsylvania, and then recently my PhD from Harrisburg University in data science. I've also been a data scientist at IQVIA, I guess, for the past 5 years, working in real-world evidence. So I know I spoke to some of you about what IQVIA is. IQVIA is basically a healthcare analytics company. We do data warehousing, but it's basically collection of data, medical claims from diagnoses, surgeries, procedures, from not from a clinical setting, but when actually patients go into an ER or an inpatient visit or to a physician's office. So it's actually a compilation of diagnoses, procedures, surgery codes, and IQVIA offers both data warehousing and healthcare analytics. And my interests are Bayesian statistics. My advisor, Dr. Alan Hitch, he's on Zoom listening. He's big into Bayesian stats, and he introduced me to this area. And since then, I read on Judea Pearl, Andrew Gelman, Richard McElreath, his book on statistical rethinking, and I just fell in love with Bayesian statistics. I do outcomes research, healthcare analytics I spoke about, and then epidemiology. Right, so what is HA? So HA is this genetic disorder that's caused by the deficiency in the C1 inhibitor protein. So in our bodies, the C1 inhibitor protein, what it does is it prevents inflammation in our body. And when there's a defect in that complement system, it leads to this inflammation, which can't be controlled. So HA patients report these strange swellings of their larynx, their face, their body parts because of this HA or an episode of HA, which can just occur irregularly. So some patients report having HA when they were mowing the lawn or when they were depressed or because of seasonal changes, climatic changes. And usually when they have these episodes, it requires some kind of a visit to an ER or an inpatient visit for treatment of HA. So these images are taken from the United States HAE Association, which does a great job in providing guidance for both patients and physicians globally to how to deal with HA and for physicians and on how to actually manage a patient's HA. So these attacks, as you can see, the internal swelling and then the external swelling happens just within a few hours of an HA episode. The reason I did my research in HA is because through IQVIA, I did a project with the US HA Association, and even though it's a rare disease, only let's say 15,000 people in the United States have it, there's not real world evidence for this study because people would really prefer to do research in asthma, cancer, or diabetes. And since there isn't much real world evidence for this study, I said, well, okay, I'll do my research in this area. So two problems that come with HA is the diagnosis and the treatment. So the problem with the diagnosis is that physicians don't rarely come across this disease. So if they don't see it that often, if a patient comes in, they might misdiagnose that patient for having something else and then start treatment for that patient for something else rather than treatment for HA, which are limited. So there's two treatment options. One is the prophylactic treatment option, which is if you have HA, you continuously take this medication and that helps you keep your HA in check. The acute treatment option is if you have an attack or an HA episode, this is what you would take to control your HA to help reduce the inflammation, help swelling go down. But if it's not appropriately controlled, then leads to renal disease, cardiovascular disease, and then long-term mortality. Which brings us to this research question. Can we look at some of patient characteristics or their comorbidities which puts them at a higher risk of mortality for HA. So by comorbidities, I mean when a patient comes in, let's say they have HA, they also have other diseases along with HA. It could be hypertension, could be autoimmune disease. What are some of the characteristics or comorbidities that put patients at a higher risk of mortality? Like I said before, this paper was published in the Journal of Health Outcomes, Health Economics and Outcomes Research, if anybody wants to read it. So what we did was we took the NIS database, which is the National Inpatient Sample, which is a record of a longitudinal record of patients who were admitted into the hospital across the United States. I think they keep records from 2003 onwards. And so patients in the NIS database were pulled for having HA, and the diagnosis code for that is D84.1. So ICD-10 codes are international diagnostic codes that are used to characterize a disease when you go into a healthcare facility. People who work in insurance might know that. So D84.1, we pulled those patients using the NIS, the most recent NIS database, that's 2021. We found 441 patients. It's a rare disease, so you're not going to see that many instances of this disease. So we had these 441 patients, and then we see their demographics. So more patients in the 40 to 64 age category, more females, more Caucasian, and then more patients on private insurance, and then kind of similar distribution for patients on Medicaid and Medicare. And we look at their other characteristics of demographics, more patients in the South, more patients in urbanized areas, an even distribution of their income percentiles. And then below we have, so the United States, 4 regions, and then below are the 9 divisions. So we see more patients in South Atlantic, some in Pacific, Mid-Atlantic, that's the higher divisions. On the right-hand side, we have the comorbidities. So these are the other areas, the disease areas that these patients have along with HA. So a lot of them have hypertension, obesity, COPD, diabetes, depression, and then we taper off down to thyroid, autoimmune disease, drug abuse, PVD, which is peripheral vascular disease, and then alcohol abuse. So we want to take these characteristics and comorbidities and try to see which of these combinations put patients at higher risk of mortality. So the great thing about NIS databases is it comes with these 2 variables, which are severity and mortality risk. So these 2 variables are created using DRG codes, which is codes used to see how much utilization, healthcare utilization a patient would need, and what would be the cost of that patient's visit. So patients that have higher severity, that's major or extreme, or higher mortality risk, are likely to incur more cost when they go into an inpatient visit. So the mortality risk is the outcome we're going to look at. And what I did was I bucketed minor and moderate into low risk, and then major and extreme into high risk. So you have 270 patients with low risk, and then 171 with high risk. And what we plan to do is look at the characteristics and comorbidities and see which of these patients can we create a predictive model to put patients into low risk or high risk given their characteristics and other diseases that they have. So a great way to do this is through, as you might have guessed, through Bayesian networks. And the great thing about Bayesian networks is, and my advisor would agree with that, is that you can DAG everything. So if you want to show somebody what is it that the variables that you have that you're going to play with, you put them on a DAG. And what that helps you with is look at the actual data generating process. Like what is it that caused, or what is it that's causing this particular outcome to appear in the first place? An interesting thing to note is that this DAG, which I'll talk about in a second, is my interpretation of how the data generating process looks like. I didn't use the data to create it. I looked at the literature to see what nodes should be connected. And I came up with this particular DAG. But that's just my assumption. If somebody else were to do it, they might have a completely different assumption and might come up with a completely different DAG, which is okay. As Andrew Gelman says, just be upfront about your assumptions. Like these are the assumptions of the framework that I'm working in. And then these are the results that come about from these assumptions. So like, for example, when Christopher Columbus set out to find India, he had a map and a compass. He had this idea of a small world, but then he ended up on the United States, which he didn't know existed between where he was starting from and India. So he had some idea in a small world that he was living in, but that didn't really apply into the real world. And that's what modeling is all about. As Richard McElreath says, we're using small world data to make inferences about the real world. So what I think, what's going on here in this DAG, we predict that as age, you're likely to maybe earn more. With age, you might have more severe disease because of physiological decline, higher mortality risk. Your income might dictate what kind of distribution, what kind of insurance that you have. With income, you might have diabetes. Maybe you're able to work out more and not have diabetes, or maybe you just get lazy and you might have diabetes. Region might affect diabetes, eating patterns, autoimmune disease, and these could all affect severity. So we talked a lot about correlation and causation. If you talk about these arcs are showing some kind of association that we believe exists between these nodes. If you talk about causation, then our interpretation of these nodes completely change. To do causation in an observational study, you have to run something called IPW, which is inverse probability weighting. You use that weighted score to come up with, to control for the confounding that exists in observational studies. So DAGs are great. You can apply them in observational data, but your interpretation has to be that this is all association. There's no causation. To do actual causal analysis with observational data, you have to do something with the inverse probability weighting. So 2 stages of Bayesian learning. So first stage I talked about is the DAG. The second stage is the parameter estimation that you use your prior, your DAG, and your data to come up with the posterior, which is your conditional probability estimates. For this study, we use 70% of the data as training data and then the remaining 30% for testing, because we're going to see if we build this model, how is it going to generalize to data that's not seen before. This is just a quick example of how we go about calculating the actual posterior mean. So your prior is a Dirichlet distribution, which is a vector that your probabilities or your each nodes should sum up to 1. It's just a generalization of a multivariate beta distribution. Then you have some observed data. So your distribution, your prior is that both categories are equal. Then you have some observed data that you, in the first category, you have 4 zeros, and second category has 6 ones. So one variable, 4 zeros, 6 ones. The posterior is Dirichlet 5.7, and then the posterior mean is 0.42, 0.58. So this is how you're going about. Bayesian analysis is just basically counting. It's counting the ways that something could occur. And you take the prior, you take the data, and you get the posterior, and you get the posterior mean. So in Richard McElreath's book, he talks about the garden of forking data. So you're walking through a garden. With a DAG, you're going to go down some aisles. You're going to go through some doors. And what you're doing is, as you're going through those doors, you're just basically counting and coming up with the outcome node. So when we take our data, prior, and our DAG, this is what we come up with that baseline. So we see the distribution of the variables in our data, and then we see for this 70% training data that patients who are admitted with HA have a high mortality risk of 41.6%. So that's kind of your baseline, what you've learned after applying your prior, your DAG, and your data. What we really want to see is what happens when we condition on specific nodes. How is it that the risk of mortality is going to change when we condition a certain node? And for that, we looked at the delta, which is the change in the conditional probability estimate compared to the baseline when you condition on a certain node. So here we see with patients that are 65 and above, you're going to see higher mortality risk. That's a given because with age comes physiological decline. For African American patients, we see a higher mortality risk compared to Hispanics, Caucasians. For patients in the lower income group, we see higher risk of mortality. For patients with major or extreme severity, so when they came into the hospital, if they had made in a severe condition, they would have higher risk of mortality. And then for the comorbidities, we see diabetes, 1.7% increase, but autoimmune shows the hardest increase in risk of mortality. So when I was doing my research, this was the best way I could come up with to paint a story or paint a picture of what's going on with the Bayesian network. Because if you learn the Bayesian network, you've shown your results, how is it that you show the actual change? Like how is it that you actually are going to put a story on what's going on with these patients? And here I've shown higher age patients, African American patients, lower income patients, autoimmune patients at higher risk of mortality. And the other great thing about Bayesian networks is the visualizations, because For some reason, I don't like black box approaches because you don't really know what's going on underneath. With Bayesian networks, you're actually doing the counting. Even though you're not getting any significance estimates, you're getting the results of that counting. And then you can condition on certain nodes to see how is it that your mortality risk is going to change. So the estimated probability, if we condition on patients, African-American patients, and then patients in, I believe it's in the Midwest on the left-hand side, then your probability increases to 50.2% from 41.6%, the baseline. And if you condition on African-American patients in the South, then the probability increases to 45.5%, so 4.1% increase. And the largest increase we found was condition on African-American patients 65 and above, and I believe it's in the Midwest, we come up with a higher risk of mortality of 59.7%. That's the highest change in mortality risk that we saw. And one quick glance at patients who are Medicare or Medicaid or Hispanic patients, they also showed a higher increase in mortality risk, so these HA patients. This is a great way to show your customers or anybody you're working with how is it that your results are changing when you're conditioning on certain nodes. And when I presented this at IQVIA, they were very interested about how is it that we're going to use segmentation to pull on certain levers, because IQVIA does segmentation. They want to know which doctors are going to prescribe more of this medication when you're going to market. How can we use this setup to show if you're pulling on certain levers, high propensity doctors, how is it that your segmentation would change, or how you can show to your customers how is it that your forecast is going to change based on how much revenue the drug is bringing in. So that's something I really like about Bayesian networks. And then how is it that you're going to validate your Bayesian network? So since this is my PhD, I had 5 committee members look at this paper, and then I had 2 peer reviewers who did 3 rounds of peer reviews back and forth on this. And obviously, you have to present some kind of validation for your Bayesian network. So the 30% testing data shows that the model is correctly predicting 82% of the time. So it's classifying the cases 82% of the times. Specificity shows that it's correctly specifying the low-risk patients 79% of the times, high risk, that sensitivity 84% of the times. But here's the problem. If you look at the bottom values, the positive predictive value and the negative predictive value, when a model comes across a patient that has high-risk HA, it correctly classifies that patient 87% of the times. But when the model comes across a patient that has low risk of HA, it only correctly specifies that patient 75% of the times, which means that 25% of the times the model is wrong. And clinical decision-making, that can become a problem because you're saying a patient is low risk, model classifies it at high risk, or a patient should be high risk, model classifies at low risk, becomes a problem in clinical decision-making. And that's something, like I said, when you have some assumptions or you have some limitations, you'll be upfront about it, is an area of improvement for this specific Bayesian network that with some other data can be improved upon is the negative predictive value, especially if you're going to deploy this Bayesian network in a clinical setting. And then the area under the curve shows for the training data and the testing data that it's able to generalize well. So what we did was train it on 70% of the data, test it on 30% of the data, and it's able to generalize. So when it's given a data set that it hasn't seen before, it's able to generalize well. And the same results we're seeing for the 5-fold cross-validation. The results I don't have up here. We ran just to see for the peer reviewers, because how you split the data between 70%, 30% might dictate how the model is training. But when you do a 5-fold cross-validation, you're changing the cutoff point every time for each fold. It's going to paint a better picture of how is it that your model is training and how is it testing on different data sets. But I think actually to test this model would be to take a completely different database, healthcare database, and then throw those variables in there and see how it does. Because the training and testing data still is coming from the same database. It's still coming from the same procedure or the same process. So the model might be able to work well. But if you use a completely different healthcare database, let's say you use Trinetics, I use NIS, you use Trinetics database, or you use IQVIA, or use Optum data, then you can actually see how is it that it's doing with data that it hasn't seen before. And like I said, with committee members and with peer reviewers, they're always going to ask about p-values. So p-values is not a way to show that your model or your results are publishable. It doesn't mean that if you have some significance by random chance or you're under the null hypothesis, your results are 2 standard deviations above the mean. That means that it's just automatically becomes something that's publishable. But to demonstrate the strength of the Bayesian network, we still ran a logistic regression to see, okay, which of these variables are actually significant for those who traditionally want to think about it in a hypothesis testing framework. So we see age 65 above as significant, autoimmune patients, patients on Medicare, second income quartile, and then on Medicaid. The other thing is the logistic regression performance in terms of area under the curve is not as good as the Bayesian network. So area under the curve, if you look at it, it's on the training data, it's 0.67, on the testing data, it's 0.61. So it doesn't perform as well as the Bayesian network. But that doesn't really mean that the Bayesian network method is better than the logistic regression in any ways. Because we can improve upon this logistic regression by adding interaction terms or by playing around with these variables that will improve the fit of the model. So even if one model is doing better than the other, that doesn't mean that logistic regression is something that's redundant or it's not important. It's still a very powerful way to get results. So the purpose of doing this analysis wasn't to show the strength of the Bayesian networks compared to the logistic regression. It was just to validate the results and show that if we use the variables as is that we put in the Bayesian network into the logistic regression, the performance in terms of validation is not the same. And yeah, with that, I come to an end of my presentation, but I'm happy to take any questions.
Thank you very much, Subhan. I see we have a lot of questions.